Hi class, this is your voiceover PowerPoint for our content for GU, and we'll get going right here. So your readings for this content, we're doing a little bit of like a physiology review of the GU system, the upper and lower urinary system, and your readings are as follows. Also going over hydronephrosis, kidney stones, and pyelonephritis. All right, so we're going to start with the structure. So just a little review, like an A and P of our urinary system. So we have our upper urinary system. It is made up of two kidneys, okay, one on either side, right and left. And then we have our two ureters connecting to our kidneys that drop down into our bladder, also right and left ureter. So two kidneys and two ureters are made up of the upper urinary system. And the lower urinary system is made up of the bladder and the urethra. And we'll go over these a little bit more in depth on the next few slides. So where is urine formed? Starts in the kidneys, right? Okay, so our urine is formed in the kidneys, and we're going to get a little bit more in depth of how it's formed in the kidneys. But the urine drains through the ureters, it's stored in the bladder, and it passes out through the urethra. So we're going to start right with the kidneys here. So we're going to go over some primary functions of the kidneys. It's really our principal organ of the urinary system. And our kidneys are made to regulate the volume and composition of extracellular fluid. They help excrete waste products from the body. They help control blood pressure, helps activate vitamin D. It makes erythropoietin, and it regulates acid-base balances. And we talked a lot about that, remember, back in respiratory. Bicarb has a lot to do with the kidneys. And so kind of putting two and two together now, this is what they're talking about with the regulation of acid-base balance. So a little bit in depth, okay? So digging a little bit deeper into the kidney, the anatomy of the kidney. The kidneys are a pair, so there's right and left, and they're bean-shaped organs, and they're located retroperitoneal. Okay, that means it's behind the peritoneum, and they're on either side of the vertebral column. And they hang about like where your T12 to L3 is on your lumbar and your spine. Each kidney weighs about 4 to 6 ounces, give or take, and they are about 5 inches long. The right kidney sits a little bit lower than the left. And on top of each kidney, it's almost like a hat. A kidney wears a hat. Those are the adrenal glands, and they lie right on top of each kidney. The kidney itself is actually cushioned by a considerable amount of fat, for any like blunt force trauma or anything that, could cause trauma to the kidney. There's quite a bit of cushioning and support. So there's a thin, smooth layer of fibrous membrane. It covers the surface of the kidney, and that's called the fibrous capsule. And I think that is labeled here. Yep, right on the bottom right here, you'll see that the fibrous capsule is labeled on this picture. And that's kind of what serves as the shock absorber for any trauma or force that may come about. Also, just pay attention what's called the ileus or ileum. That's actually, there's an opening to the kidney, and it's on the medial side, so the inner sides of the kidney. And it's really an entry site and exit site. Okay, so your renal artery and your nerves, and it's the exit site for the renal vein. So if you can see the renal veins in purple, and that's the exit for the renal vein. And the renal artery would be the red. It's kind of behind the purple here, and that would be the entrance. Okay. It's also the exit for the ureter. So as you can see, there's a renal pelvis coming off of the ileum, the opening, and that connects right to the ureter. Renal cortex. It's a thick outer layer of the kidney. Okay, and that is labeled, that's the top label here. And then the inner layer is known as the renal medulla. Okay, and that actually consists of a number of what they call pyramids. They actually look like little triangles here, renal pyramids. The top of the pyramids are actually the points. So don't think as the top is the outer portion, the more wide portion. The top of these are actually the pointed part of the pyramid. Okay. So the urine passes to enter what is called the calyces. So if you see there's a major calyx and a minor calyx, and these are labeled here on the bottom of the kidney. So the minor calyx comes right from the top of the pyramid, and then the major calyx is more of the thicker portion that brings the urine right into the renal pelvis. The renal pelvis itself can actually store about 3 to 5 milliliters of urine within that little small renal pelvis. And moving on. This is just a nice little video giving a little bit more in depth of the, a little bit more of A and P of the urinary system and the kidney. So we're going to dig a little bit deeper into the kidney, okay? So I don't know if you remember this, but the nephrons, okay? This is actually the microstructure of the kidney itself, and there is about 1 million nephrons in each kidney. A big part of the nephron is actually the glomerulus, and that lives within the what's called the Bowman's capsule. Okay, as you can see, there's this bigger picture here that's more magnified. We have the Bowman's capsule, and as you can see, the glomerulus lives right inside of that capsule. So the nephron is actually like a tubular system. It's made up of a proximal tubule, distal tubule, loop of Henle, all which are located within the cortex except the loop of Henle, and that is located within the medulla portion. So how many milliliters of blood do you think gets filtered through the kidneys per minute? 1,200 milliliters per minute. And that actually accounts for about 20 to 25% of cardiac output. So how does the blood enter the kidneys? We talked a little bit about this. Remember the helium or hileus? It's that opening. And the blood enters through the renal artery. And how does it exit? Through the renal vein. So the whole nephron itself is actually responsible for filtration, reabsorption, secretion, excretion of water, electrolyte balances, and also waste products. We'll go through a little bit in depth in the next few slides about that. So glomerular filtrate. What happens within the glomerulus? And we know that the glomerulus sits within the Bowman's capsule. We saw a picture of that. And there's a collection of actually 50 capillaries. So blood urine formation begins and blood is filtered within the glomerulus. And what is the filtered portion called? Glomerular filtrate. And what is this filtrate composed of? So this filtrate is like the composition of blood, except that it lacks blood cells, platelets, and large plasma proteins. Under normal conditions, capillary pores are too small to allow the loss of these large blood components. So a lot of times if a patient does have kidney disease or end-stage renal disease, they have a little bit more capillary permeability, which increases, the amount of plasma proteins and blood cells that could be found in the urine. So that's why if a patient is more end-stage renal or has some renal disease, we can pick up actually the proteins and some hematuria within the urine in the urine tests. What is glomerular filtration rate? It's actually the amount of blood filtered each minute. And how many mLs per minute? 125 mLs per minute. Only 1 milliliter a minute of filtrate is actually excreted as urine. Most of it actually gets reabsorbed within the nephron. So this is what I want you to know just about the segments of the nephron, okay? So we have, I know Lewis, our textbook goes into great lengths of describing the tubule functions, but please just know this information only. So the glomerulus, it's for selective filtration. Urine formation begins, our blood is filtered. Then we have the proximal tubule, and the job of that is for reabsorption of 80% of electrolytes and water, as well as glucose, amino acids, and bicarb. The loop of Henle, its job is for concentration of filtrate, for reabsorption of sodium and chloride, and in the ascending limb and water in the descending loop. Then talking about the distal tubule, that's job is for reabsorption of water and bicarb, as well as regulation of sodium and potassium and secretion of potassium and ammonia. And then the collecting duct is for reabsorption of water, and that requires ADH, antidiuretic hormone. Okay, so other functions of the kidneys. So what hormone is made in the kidneys? That would be erythropoietin, yes. And what does erythropoietin stimulate? It stimulates red blood cell production in the bone marrow. And when is erythropoietin secreted? It's secreted in response to hypoxia and decreased renal blood flow. When is a deficiency seen in erythropoietin? Kidney disease. And what does this deficiency cause? Anemia. Okay, so that's a big one. We do see a lot of end-stage renal disease, chronic kidney disease patients tend to have lower hemoglobin levels, H&H levels, tend to be a little bit more anemic, and that is why. And what protein helps regulate blood pressure? And that would be the protein renin. And it's actually made and secreted by the kidneys, and it's released into the bloodstream in response to decreased renal perfusion or even decreased arterial blood pressures. So the kidney is a big participant in red blood cell production and also blood pressure regulation. And this is a good video. It really digs deep into the nephron. You can get a good visual of the nephron, and it talks about the different parts like the loop of Henle, the ascending, descending tubule, kind of the important ones that we talked about on the previous slide. All right, that's it with the kidneys, okay? So we're going to move on to the ureters, and they branch off of the kidney, okay? So the ureter is actually attached to that. You see this thicker portion that comes off of the kidney here, that's the renal pelvis. And the ureter comes right off of that renal pelvis and attaches itself into the bladder on either side. So each ureter is about 10 to 12 inches long. The outer layer of the ureter is mesh-like. It's definitely it's made up of smooth muscle fibers, and the ureters can actually create a little like peristaltic motion, almost like the intestines, to push urine downward. So these are tubes, on either side. They carry urine from the renal pelvis right into the bladder. And like I said, they extend off the renal pelvis and they insert themselves on either side of the bladder base. The they're chock full of nerves though. So the sympathetic and parasympathetic nerves, they actually run right through the lining of the ureters. So think about when a patient's like, if we're going to talk about stones in a little bit, but if they're passing a kidney stone, where do you think that's going to be most painful? Definitely the ureters, because they're chock full of a lot of nerve fibers. So the passage of a stone makes it very painful to pass once going through the ureters. Right here at the renal pelvis, as it breaks down into the ureter, um, this is a point, it's called the ureter-pelvic junction, or the UPJ. And again, that's where the ureter meets the renal pelvis. And then there's also an area where the ureter meets the bladder, okay? And that is actually called the ureterovesical junction, the UVJ. Meets the bladder. So if you think about it, what helps me remember UPJ versus UVJ, just think of the alphabet. P comes before V, right? And P, the uretopelvic junction, is higher and it's coming before the UVJ. So uretopelvic junction is up top. The ureterovesical junction is down at the bottom where it meets the bladder. They typically say these two spots, where they meet, they tend to be a little bit more narrowed, and it can be very common for a stone to get stuck in either the uretopelvic junction or the ureterovesical junction, just because of how narrow it is of where it attaches anatomically. Next, we're going to talk about the bladder, and that's located behind the symphysis pubis, and it serves as a reservoir for urine, and it eliminates waste from the body, and it's a very stretchable sac-like organ. So what do you think the normal adult urine output per day is? And that would be 1,500 mLs per day. And how much urine can actually cause distension? 200 to 250 mLs can actually start to cause moderate distension, really soliciting the urge to void. And then when we get to about 400 to 600 mLs in the bladder, that's when the patient or even yourself may feel uncomfortable. And then bladder really reaches full capacity, from about 600 to even a liter. And that's kind of dependent with every patient. Every patient's different. Everybody's different. Some people can hold their urine a lot longer than others. So it's just how much that sac-like organ is able to stretch. So it definitely ranges from person to person, but they say 600 to a liter is actually capacity. We see that urine volume at night is less actually than half of what's formed during the day. That's actually due to hormonal influencers such as ADH, as antidiuretic hormone, and that's completely normal. A person on average urinates about 5 to 6 times during the day, possibly maybe 2 times overnight. Normally, that's at the most. And then moving on to the urethra. So that's the exit tube. So it's a small tube exiting the bladder, extending out to the external meatus. And that actually helps us control voiding. It serves as an exit conduit. The female urethra is about 1 to 2 inches in length. Male is about 8 to 10 inches in length. So next we're going to talk a little bit about assessment abnormalities just with the urinary system itself, okay? We're not going to get into the disease processes just yet, but I thought this would be interesting to at least go over these abnormalities. So what is anuria? That would be no urination. That would be at least in a 24-hour period. We'd see less than 100 mLs out. So we really see this in acute kidney injuries, especially if a patient was severely dehydrated, or end-stage renal disease where they're just not making urine. Obstructions, we can see this happen. And then moving on to burning with urination. When do we typically see that? Yeah, UTIs, possibly obstructions, dysuria, and that would be painful urination. And we can see that also with UTIs and obstructions. Enuresis, that's involuntary nocturnal urination. And that could be a lower urinary tract disorder. Frequency, that's increased incidences of urination. Okay, so it can happen with retention or overflow, UTI, or obstruction, even excessive intake of fluid. Hematuria, that's blood in the urine, okay? So we can see that in sometimes bladder cancer, kidney disease, UTIs, kidney stones, or patient may be on anticoagulants. Next, we have hesitancy. So that is actually more of a delay. Okay, so delay or difficulty initiating the urine stream. And that could be from obstruction, an enlarged prostate, urinary tract infection. Incontinence. So that's the inability to control the urine discharge. That could be from anything from a neurogenic bladder, an infection, injury to the external sphincter. Oliguria. So a little bit more urine than anuria, okay, but along the same lines here. So possibly in a 24-hour period, we may see 100 to a max of 400 mLs, okay, in a 24-hour period. So this could be from, again, acute kidney injury as well, also known as dehydration. It could be from shock, transfusion reactions, kidney disease, end-stage renal disease. Pneumaturia, we don't hear this one too often. And that's the passage of urine containing gas. So there can actually be fistula connections between bowel and bladder. So really a gas-forming UTI. Polyuria, so large volume of urine in a time period. So excessive urination. We see this a lot with like diabetes, especially diabetes insipidus, or a patient may be on diuretics. It could be excessive fluid intake. We see this with obstructive sleep apnea. And then retention. So we're holding on to urine, right? So inability to urinate even through the bladder. Even though the bladder contains urine, we can't get it out. What can, cause this is childbirth, catheter removal, anesthesia, urethral strictures, neurogenic bladder. And then stress incontinence, very common. It's an involuntary urination, has increased pressure. With any increased pressure, if a patient were to cough, sneeze, it's just from weakened sphincter control. All right, moving on. Okay, so moving on to our disease processes. So starting off with urinary obstructions. A urinary obstruction is a condition that blocks or impedes the flow of urine. So an obstruction can either be, congenital or acquired, and we'll talk a little bit about that. And really the severity of the obstruction depends on the location of it and how long the obstruction has been there. And if there's any presence of like urinary stasis or infection. So if urine's been sitting for a while, we're going to probably have increased, bacteria, right? So we just have to be cautious with that. Infection can increase the risk of irreversible damage, really. So where do damaging effects occur if your patient has an obstruction? So think about it. So if you have a stone that's in the middle of your ureter, and our kidneys make the urine, and the urine's trying to get down through the ureter, but it's not, where's that damage going to happen? Above, right? It's going to happen above the obstruction, okay? Good. So hydronephrosis, okay? So hydro meaning water, nephro meaning kidney, and cis is really a disease state, okay? So it's really water within the kidney. And it's, dilation or enlargement of the renal pelvis caused from backflow of urine. So we have some sort of obstruction that's causing backflow, and it's causing water within the kidney to swell, okay? So it's really excessive amount of water, urine, really, causing the kidneys to dilate and inflame and swell. This can happen in one or both of the kidneys, depending on where the obstruction may be. Sometimes if only one kidney is obstructed, the other kidney may try to compensate by enlarging. And if only one kidney is affected and one kidney is functioning, it may be possible for our patient to really be asymptomatic because the other kidney is going to take over, okay, and help with the urinary obstruction. Okay, so moving on, causes of hydronephrosis. There's a few of them, and this is, again, hydronephrosis is the backup of water or urine into the renal pelvis and the kidney itself, causing the kidney to swell. So we have bladder outlet obstruction, and this happens when pressure increases during bladder filling, and this pressure in the bladder leads to backflow or reflux right into the ureter. And we get what is called a hydroureter, which is dilation and distension of the ureter itself. And then we have vesicoureteral reflux, and this is actually a reflux from the lower urinary system to the upper urinary system. So the urine, again, is flowing backwards through the ureter from the bladder up into the kidney. So they're very similar. Bladder outlet obstruction and the vesicoureteral reflux are very similar in concepts. So again, just as some examples as what can cause backflow or an obstruction would be kidney stones. It could be a tumor located in the abdomen or in the pelvis, an enlarged prostate, or known as BPH, even compression from pregnancy from the fetus, and problems actually with nerves that can lead to the bladder. So an obstruction can really occur at any location along the urinary tract, okay, whether it's the upper urinary system or the lower urinary system. And I wanted to talk about two areas here. So there is an area where the ureter is actually connected to the renal pelvis, okay? So the ureter connects to the kidney through that renal pelvis. And where that connection is called the ureteropelvic junction, or also known as the UPJ. And then there's the ureteral vesicle junction. So the ureter connects to the bladder, right? So the area where the ureter will connect to the bladder is known as the UVJ. This is kind of easy to remember for me because I think of the alphabet. So UPJ is above, so it's higher in the alphabet than UVJ. So if that's something that can help you remember where the UPJ is located versus where the UVJ is located, that is what always helped me. P is before V, and P is higher up in the urinary system than V. Okay. So these areas, the UPJ and the UVJ, can be very common areas for actually where obstructions can happen, especially stones, because there's a type of narrowing at this area, at the UPJ and the UVJ. So that can be a common area for obstruction. There's also something that is called a ureteral cell. That is a balloon-like obstruction the end of the ureter that goes into the bladder. Okay, and that is actually more an anatomical issue. Then there's the congenital ureteropelvic junction obstruction. So again, the UPJ, and what happens is that opening where it should be going into the renal pelvis, it actually fails to canalize or create a wide enough tube. So it's very, very constricted, and we see this often on ultrasounds for babies, and that is picked up. We can actually see a little hydronephrosis starting in the unborn baby. And that can be a lot of congenital issues, the ureteropelvic junction obstruction. And then children who have the ureteral cell, which is, again, that sac of tissue, which is at the end of the ureter by the bladder, obstructs the urine. And also there's obstruction right at the urethra, so there's no opening or really no meatus at the end in boys. And again, that's causing obstruction and backflow of urine. And this is just a slide. I like this slide because it shows the whole urinary system, upper and lower. And it's showing actually where obstructions can happen. So if we start up at the top here in the renal pelvis, an example of some obstructions that can happen there is actually cancer cells, so transitional cell carcinoma right in the renal pelvis. Again, the ureteropelvic obstruction. We talked about being more congenital in the babies. And of course, renal calculi, so renal stones. And it's pointing here, if you go below, pelvic ureteral junction obstruction. So there could be a stricture, which is more anatomical, and then we can have a stone as well. We move down to the ureter itself, and here's a stone right within the ureter causing obstruction. There could also be a tumor. Again, more on the external side, we could have pressure from a fetus from pregnancy, tumor of the cervix pressing on the ureter, retroperitoneal fibrosis or endometriosis can cause issues such as that. Moving down to the lower urinary system, we have the bladder, which there could be a bladder tumor causing obstruction, again, calculi or stones, and neurogenic disorders. The urethra, there can be a posterior valve stricture, and like I said, a meatus stricture. And then the prostate, so BPH, enlarged prostate, also prostate cancer as well. And this picture just shows you the developing stages of hydronephrosis and how severe it can actually get. So this first picture here is pretty normal. We have a normal size renal pelvis, which goes right down into the ureter. Excuse me. Our renal cortex looks normal. Our pyramids look normal. Nothing really looks too inflamed here. And then on the next one, our renal pelvis is getting a little bit enlarged, so we're having an obstruction and we're having inflammation and backflow into the renal pelvis. And then on this third picture here, we can actually see a little bit more swelling right into the kidney now. So our pyramids are enlarged, okay, and our renal pelvis is huge. And then we have total inflammation of the kidney in the left, this last picture here. Our renal pelvis is extremely inflamed, our kidney is inflamed. We cannot even really see our pyramids anymore. And then, you know, this is just a good example of how hydronephrosis can develop. So signs and symptoms, okay, what do these patients really feel like when they have hydronephrosis? So they're going to have pain in the side and the back, okay, also known as what we know flank pain, right? So pain in that right behind the kidneys there in the back, and that pain can travel even to the lower abdomen or groin. They almost feel like symptoms of a urinary tract infection. They may feel a little bit of burning sensation when they're trying to go. They're trying to go, but they can't. Maybe pain with urination, feeling of urgency or frequency and need to urinate. Post-renal azotemia. They could develop nausea, vomiting, fever, especially because of the inflammation. So this post-renal azotemia is actually the obstruction of urine flow causes the kidney to increase reabsorption of urea, which increases nitrogen-containing compounds in the blood. So how do we diagnose hydronephrosis? So renal ultrasounds are very common. For issues with unborn babies, of course, prenatal ultrasounds for the neonates. Intravenous urography or pyelography, those terms are both one of the same, and these are both common in pediatrics. A CT scan is very, very, very common. So renal ultrasounds and CT scans are common in adults. And just going back to that intravenous urography or the pyelogram or pyelography, it's a test that uses x-rays and a special dye, and it helps assess the kidneys, ureters, bladder, and urethra. So it's actually kind of following the urinary tract and the flow of urine, and it kind of helps to see where the backflow would be. Labs, what would we do for labs? Probably definitely want to get a CBC, right, and see if that white blood cell count is elevated. We want to see how our kidney levels are doing, so our BUN and creatinine. So we would want to get those levels. We could have elevated potassium levels just due to acute kidney injury. And we could do a UA that may show, increased white blood cells or even red blood cells due to inflammation. And then we have some hydronephrosis grading, okay? It's called the Onan hydronephrosis grading system. So we have grade 1, where the renal pelvic dilation is just that of itself. Okay, so it's more dealing with the renal pelvis than anything. Grade 2, we have the renal pelvis inflammation, and it goes into the calyces. So we're getting more into the pyramids here, okay, the fingers that branch off into those pyramids. Grade 3, we have the pelvis and the calyces, and then the medulla of the kidney becomes short and thin, and the cortex remains normal. And then grade 4, again, we have large inflammation of the pelvis or renal pelvis, large inflammation of the calyces. The cortex is actually now thinning, and we have huge inflammation of the kidney itself. So treatment, how do we treat hydronephrosis? So we have to look at the underlying cause, right? So what's causing the obstruction? And once we figure that out, we'll have normal urinary flow again. So we have to look at the underlying cause. In the meantime, while looking at the underlying cause, sometimes we may need to insert like a urethral tube or a stent to help relieve some pressure off the kidney, relieve some pressure off the renal pelvis. So in the meantime, relieving pressure is a big deal as well. So either by a nephrostomy tube, that tube is inserted right into the kidney itself and drains the urine above the issue of the obstruction. Also, urethral tube or stent can maybe help maneuver possibly around like a tumor or some sort of obstruction to help the urine pass through the ureters. There may need to be surgical correction, especially if it's an anatomical issue. So if there is a meatus that has no opening, or if there's a stricture at the, the UPJ or the UVJ, or if there is actually that anatomical obstruction at the UPJ or the UVJ. So just creating that diversion of urine is really, really important, and that's going to be above the level of the blockage, okay? If there's a lower obstruction, more like a BPH or a prostatic type of obstruction, a Foley catheter could be very helpful in that. So depending what the underlying cause is, we have to try to, either take out a stone or break up a stone, let the stone try to pass, in the meantime, putting in, an insertion of a urethral tube or stent or a nephrostomy tube. If there's a tumor, is it operable? How can we relieve pressure around the tumor? And then, surgical correction if there's any strictures. And this is a video on hydronephrosis. Okay, so we're moving on to kidney stones here. So fancy name, nephrolithiasis, meaning stone formation in the kidney. Nephro meaning kidney, lithiasis meaning stone formation. So also known as renal calculi, renal stones, kidney stones. Okay, so they're very hard deposits. They're made up of minerals and salts from inside your kidneys. So risk for developing stones definitely increases with age. There's a higher incidence of patients more with a family history of stone formation, and we find that higher incidences for family history. Reoccurrence, once someone has had a stone, we see about 50% of patients have reoccurrence of kidney stones. US actually has the highest rate in the Southeast for kidney stones, and that can be very dependent on diet. And these stones actually tend to occur more often in the summer months or hotter climates. If people live more in the hotter climates where they're a little bit more dehydrated, they're not taking in as much fluid intake, we could see a lot more kidney stones in these areas. So just examples of where a kidney stone can form. So we have a stone right in the bladder itself. We see the ureter has a stone. And then we have that, what is this area right here? The uretopelvic junction. So a stone is obstructing that quite a bit. We can also get stones right within the kidney itself. So risk factors, what causes kidney stones? So again, like we mentioned, warmer climates. So there's an increase of fluid loss. We have, patients may sweat a lot more in hotter climates. They're not taking in as much water, PO intake, and they have lower urine volume and increased salutation and increased concentration of the urine. So that can have an increased risk in kidney stones. Diet is a big factor in kidney stones. So if there's any intake of excessive amounts of tea or fruit juices, it actually increases urinary oxalate. If there's a large intake of dietary proteins, we can have an increase in uric acid excretion. A large intake of salt, a low calcium intake, and a low fluid intake, of course, will increase our urinary concentration. Genetics, okay, that can be a big deal to why stones may form. And lifestyle, so a patient that is a little bit more immobile, obesity, is there a sedentary occupation, and even metabolic. So that's abnormalities that can increase urine levels of calcium, oxalate, uric acid, and citric acid. So any metabolic issues that the patient may have as well. This is a great video that I really want you guys to know. So really take good notes on this. It goes over all the different types of stones and the causes of them. And it's going to go over all of these. So it's going to talk about calcium oxalate stones. It's going to talk about calcium phosphate, crystine stones, struvite, and uric acid stones. So calcium stones are actually the most common type of stone to have. They're pretty small. They can easily get trapped in the ureter, more common typically in men. We see this when there's high levels of calcium, so hypercalcemia and hypercalciuria. Also hyperoxaluria, so we have increases in oxalate. The diet for this can be very rich, foods rich in oxalate. So examples of this is rhubarb, spinach, chocolate, nuts, and beer. So what we need to do for these patients, we have to increase hydration. We have to reduce dietary oxalate, so reduce whatever their intake if they have high intake of the foods that we just mentioned. decrease any intake of sodium or having a sodium restriction, and also animal proteins. Okay, so that's like kind of liver, scallops, also increasing an intake of calcium, fruits and vegetables, and giving potassium citrate can actually help maintain an alkaline urine. So potassium citrate will help with that. Calcium phosphate, we have more alkaline urine actually, so we see hypercalcemia, hypercalciuria. We want to increase hydration with calcium phosphate. We want to reduce sodium, animal proteins, increase calcium intake. The cysteine stones is very genetic, and it's actually an autosomal defect, and it's a defective absorption of cysteine in the GI tract. So the urine is very acidic. So we want to increase hydration with these patients. We want to give potassium citrate, which will make the urine more alkaline. And we want to give captopril to prevent cysteine crystallizations. Then we go on to struvite stones, so it's actually more common in women. It's associated a lot with a UTI and the bacteria Proteus. So we need antimicrobial agents for this. The patient will need antibiotics. And these stones are very rough looking. They're like staghorn. So sometimes surgical removal is an option for these type of stones. And then uric acid stones. So these are very predominant in men, tend to be more Jewish men, patients who have a huge history of gout. The urine is very acidic. Again, if the urine's acidic, we want to give potassium citrate. It'll make the urine a little bit more alkaline. So we want to reduce purines. We want to hydrate and giving allopurinol. Signs and symptoms of a kidney stone. It's pretty rough, right? So the patient's going to have very, very severe sharp pain. It begins very, very sudden and it's acute. Where is this pain going to happen? Typically the back, so flank pain, back pain, sometimes in the lower abdomen. Due to the severe pain the patient may be having, they could develop nausea or vomiting. It's almost like they're in like a shocky type of state because of how much pain that they're in. And again, where are the common sites for obstruction for stones? The UPJ, UVJ, absolutely. And can kidney stones be a cause for hydronephrosis? Yes, absolutely. Patients who you see in the acute phase of having a kidney stone they call it the kidney stone dance. They just cannot sit still. They don't know where to put themselves. They're in so much pain. It's really the most excruciating pain a person can endure. And they call that renal colic, okay? So what happens with renal colic is there's stretching, there's dilation, there's spasms of the ureter, and that's in response to the stone trying to pass. So our really main goal here is pain control in the acute phase. Again, like I said, the patient may present more in like a mild shock type of state. They'll have like that cool, moist skin, they'll be sweaty, and most severe pain, nausea, vomiting. They'll almost have like UTI symptoms as well, so they'll feel like they have the urge to urinate and sometimes they can't, sometimes painful urination, fever, chills, frequency of urination. And diagnostics, so a CT scan, non-contrast CT scan can definitely pick up some stone formation. Renal ultrasounds are very common as well. And we want to get the measurement of the stone as well to see how big the stone is. Is the patient able to pass it? Are we going to have to break it up? Is it going to have to be surgically removed? We want to do a UA, and that can assess for what? It can be hematuria, so blood in the urine. We can see crystallized formation in a UA, and we can also measure the urine's pH level. Even getting retrieval and analysis of the stone can be really important for diagnostics, especially if the patient's having recurrent issues. So what kind of stone is forming? What kind of stone are they recurrently have? And sometimes it can be a huge diet issue where we really need to have a strict diet because of the stone formation, or is it bacterial and the patient needs to receive antibiotics? So really getting the analysis of the stone can be very important for diagnostics and fixing the underlying problem, and hopefully not having any more reoccurrences. A 24-hour urine specimen can be very beneficial for patients, especially with the recurring stones. So what other labs do you think can be helpful? Yeah, getting a calcium level. How's our calcium, phosphorus, sodium, potassium, bicarb, uric acid, BUN, and creatinines, of course. That'll help, how much kidney injury is going on. But a lot of these electrolyte levels can help us, if they're higher or lower, see what's going on with their diet and why these stones are forming. So treatment. So we need to manage the acute attack first, right? So how do we do that? Pain control is huge. So we need to manage their acute attack with pain control. It can be opioids, NSAIDs. Most stones that are about 4 millimeters or less can hopefully be passed spontaneously, but it may take weeks. Every patient's different in how long it takes to pass a stone. We want to get a good history. What do we want a history of? Family history. What's their diet like? Where do they live? Do they live in warmer climates? How's their hydration or PO intake for fluids? How's their lifestyle? Are they more sedentary? Are they active? Also in men, do they have BPH? We have a treatment, actually, this is used more for BPH in general, Flomax or tamsulosin, but this actually can be used to help with relaxation of the ureter muscles. So the muscles in the ureters can relax, which can at least help the stone pass a little bit easier. So sometimes when patients have stones, they'll be given Flomax to help with ureter constriction and help to relax the muscles of the ureters. There's also acetohydroxamic acid, and this may be used to treat kidney infections from struvite stones. Okay, so it helps relax muscle tissue in the prostate for men who have BPH. And that bullet here should actually be up with Flomax. So it helps relax muscle tissue in the prostate for men who have BPH. Okay, and the acetohydroxamic acid is used to treat kidney infections from the struvite stones. Sorry about that. IV fluids is a big one. Okay, so we want to make sure the patient's hydrated. Sodium restrictions. Okay, so an increase in salt really can create stone formation. So again, what this acetohydroxamic acid does is it inhibits the chemical action caused by the persistent bacteria of the struvite stones, and it will slow struvite stone formation. And again, which bacteria is the most common for struvite stones? And that would be Proteus. So there's endourology procedures. So we can do a cystoscopy, and this is a procedure if there's a smaller stone, and typically if the stone is in the bladder. So there's a cystoscope. It's a little hollow scope or a hollow tube, and it's inserted right into the urethra, and it's advanced into the bladder for smaller stones. Then there's the cystolithoplasty, and this is for larger stones in the bladder. And again, a cystoscope is used. It's inserted into the urethra, advanced through the bladder, and the larger stones are actually broken up with an instrument called a lithotrite. So it's a mechanical crushing and laser energy. And afterwards, the bladder is irrigated, and the crushed stones and whatnot are flushed out and voided out. Then there's a cystoscopic lithotripsy, and this uses ultrasonic waves to break up the stone. So again, a cystoscope is placed in and through the urethra, advanced into the bladder, and that is used to break up stones by ultrasonic waves. And then there's the percutaneous nephrolithotomy. So this is actually a nephroscope, and that's inserted into the kidney pelvis, or into the kidney, through the skin, through the back, and the stone fragments are broken up by ultrasound or laser, and they're removed and the renal pelvis is irrigated. Complications with these procedures, there could be bleeding, hemorrhage, retained stone fragments, and sometimes infection. And of course, this nephrolithotomy is definitely more invasive because it's going through the skin, through an incision. And then there's a lithotripsy. So we have laser lithotripsy, extracorporeal shock wave lithotripsy, ESWL, percutaneous ultrasonic lithotripsy, and electrohydraulic lithotripsy. So our laser lithotripsy is actually, they shatter urethral and large bladder stones with a uretoscope. The tip actually comes in contact with the stone itself and it emits the laser energy. It's minimally invasive, but it does require sedation or general anesthesia because the patient does need to remain extremely still. Also with the extracorporeal shock wave lithotripsy, this patient will need, again, sedation or anesthesia to remain still at all times. And this is used under fluoroscopy or ultrasound. And there's a lithotripter that's going to hover over the affected kidney, okay? It doesn't go through the skin, so it's just hovering on the back. And high volume shock waves are delivered through the skin to the kidney to shatter the stone, and then hopefully the stone is excreted through the urine. And then there's percutaneous ultrasonic lithotripsy. So this is a little bit more invasive. An ultrasonic probe is placed into the renal pelvis by a percutaneous nephroscope, and a flank incision is made, and the probe is placed right against the stone itself, and it sends the ultrasonic waves, and it breaks up the stone right into sand. And again, the sand is excreted through the urine. So kind of the same thoughts between the extracorporeal shock wave and the percutaneous ultrasound. One is just going right through the skin into the kidney, and the scope is placed right against the stone itself for percutaneous. The extracorporeal shock wave, again, is hovering right over the kidney, not going through the skin. And then there's the electrohydraulic, and this is a probe that is positioned directly on the stone, but it breaks up the stone enough to be removed by forceps. So this tends to be a bigger stone. So it can be removed by forceps or suction, and a continuous saline irrigation will be needed to flush out any remaining particles, and any outflow drainage is strained when the patient voids. Commonly, after any lithotripsy procedures, a self-retaining stent is placed, which can help the passage of, larger sand particles or larger stone particles that may have not gotten out with the lithotripsy procedure. And typically that stent is removed in about 2 weeks. And then for stones that just cannot be broken up or can be passed on their own, we do have surgical procedures as well. So if the patient's having just increased pain, the pain's not getting better with stone passage, infection. Okay, this is where we want to get the stones out quite quickly because we don't want to maintain an infection within the patient's body, or an obstruction that can't be treated. So we need to treat the hydronephrosis, and if we're having continued hydronephrosis, that's an issue to the kidneys. So that's where surgical procedures would be helpful as well. So a nephrolithotomy is actually incision right into the kidney itself to remove the stone. A pyelolithotomy is actually an incision into the renal pelvis for stone removal. A ureterolithotomy, incision right into the ureter for stone removal. And then a cystotomy is an incision to the bladder, okay? So think of lithotomies, otomies, incisions, removal of the stone. And the first part of the word, whether it's nephro, pyelo, ureteral, cysto, is the location in the urinary tract. So again, complications with these, huge, hemorrhage could be a complication, and also infection. So nursing, how do we want to, how do we care for patients with kidney stones? So of course, we're treating the acute phase first, right? So we're treating the pain. We may have to give opioid pain medications, NSAIDs to help in that acute phase, the renal colic phase, and get them through that. We need to maintain IV fluids as well, or PO hydration, whatever is best for the patient. Sometimes they do both right off the bat if the patient can take in PO, and then they'll give IV fluids as well. But should fluids be forced or run really, really fast, like bolus infusions? They really should not. It's forcing excess fluids is really not advised with kidney stones, even though we think it would push the stone out a little bit easier or faster. It's really not going to it's not going to cause spontaneous passage of stones. All it's going to do is really increase the renal colic pain and increase the acute pain level for the patient at that time. So we really need to be very careful with maintaining a proper flow rate with the patient's IV. Straining urine is very important as nurses. So with every void, we need to make sure that we're straining the urine to see if we can catch the stone. We need to monitor urine output, so get good and proper measurements. How much are they voiding per day? We want to maximize urinary output. Again, forcing fluids is not promoted. But if we can, even help the patient with turning and repositioning, just to get a proper void, maximizing urine output. Do they need to sit or stand instead of using a bedpan or a urinal? So we need to make sure that the patient's in the most comfortable position and when they're voiding. Pain relief we talked about. Diet we need to maintain. So low sodium diet is really important. We will need to restrict purines and oxalates. So some examples for that, again, the spinach, the rhubarb, asparagus, cabbage, tomatoes, beets, nuts, chocolate, cocoa, and coffee are all really good examples of oxalate diet. More examples of purines, like a high animal protein diet, would be sardines, mussels, liver, kidney, venison, herring. And we need to monitor labs. So what labs would you monitor as a nurse? So BUN and creatinine, okay? We want to monitor if the patient's having acute kidney injury. Monitoring the electrolyte levels, potassium, phosphorus, magnesium, bicarb. How much should the patient, what would we like a good output per day for our patient for a goal? Yeah, 2.5 liters per day would be a great goal for a patient who is being cared for a kidney stone. If there's any drainage bags, we do need to monitor that. So if they did get a nephrostomy tube placed, monitoring the drainage bag. If they have a Foley bag, of course, monitoring that. If they had to have surgery, monitoring any surgical site incisions. And then a nephrostomy tube. So we talked a little bit about a nephrostomy tube, and this is a good video to show how it's placed. But really what this does is it's going to help us preserve the renal function, especially if there's an obstruction. So if we have an obstructive stone and it's pushing urine and fluid up into our kidney and our kidney's swelling, pretty soon it's going to have, that fluid's going to have nowhere else to go, okay? So we need to relieve the pressure of the kidney. So a tube is inserted directly into the kidney to relieve pressure and remove urine. For that tube itself, do we ever want to kink the tubing or clamp it? No, absolutely not. We always want to check the incision site, okay? So we need to monitor for any redness, drainage around the site, possible infection. Does the site is it draining pus? Is it inflamed? It shouldn't be very, very painful for the patient, and if they have increased pain at that site, the provider should be aware of that. We want to monitor the output of the bag, how much is there in the bag per shift, what's the color of it, the amount, and the nozzle. Okay, there's a little nozzle on the end of the bag and it spins. And prior to each removal of urine, when you turn the nozzle to remove the urine, we really should be wiping that with alcohol. And again, when you close it back up, wiping it with alcohol again, it's just going to prevent any infections. It's pretty much like you're scrubbing the hub on an IV, but you're doing it to the nozzle of the bag. We do want to be careful. A lot of times this is pinned to the patient's gown or Johnny, and if we are removing the gown or Johnny, we do want to make sure that we have unpinned it. We don't want to be pulling any nephrostomy tube out. But pinning is a good idea too, because it's not going to flop on the floor. It's going to create, a little bit of tension there. So we don't want any tension on the area of the nephrostomy tube. So it's going to relieve some of that by pinning that bag. And moving on to acute pyelonephritis. So this is actually, it's an infection, right? Okay, so it's inflammation of the renal pelvis due to an infection. And it actually begins with colonization and infection of the lower urinary tract. Okay, so what's very, very common is urinary tract infections. The most common is E. coli, Proteus, Klebsiella, and Enterobacter. And so think of this, so there's actually a reflux of urine and stagnant urine from an obstruction, and that's entering the renal pelvis and causing inflammation and colonization, and that's going to cause pyelonephritis. So CODIs can be a common cause to this issue, catheter-associated urinary tract infection, and we'll get a little bit into that. So signs and symptoms. So this is, think of this as a huge UTI. Okay, so the patient's going to develop fever and chills. They may develop some flank pain. They'll have nausea, vomiting, diarrhea, just that sense of malaise, not feeling well, tired, fatigued, dysuria, painful urination. They may have that feeling of urgency, the feeling of frequency to void. But what we tend to see a lot with this infection is what's called costovertebral angle tenderness. So it's a CVA pain, and that can be present on the affected side. And this is a good diagram here or picture to show you how a provider would check for that CVA tenderness. So it's pretty much, we're palpating or percussing really right below that 12th rib. So he's hovering right over the kidney area, okay? And the patient's going to have a lot of tenderness and pain in that area. So how do we diagnose this, okay? How do we diagnose pyelonephritis? So getting a good history and physical. We want to do that urinalysis, and what may the UA show? Yep, pyuria, white blood cell count for sure, bacteremia, bacteria, hematuria sometimes just because of the inflammation and infection. Urine cultures are most important, and why is that? We get to know the sensitivities, right? So we can see how we are going to treat this patient and what type of antibiotic that they should be on depending on their cultures. So getting a urine culture is really most important for the diagnostic tool for pyelonephritis. We have ultrasounds, and what are we looking for an ultrasound? Yeah, backup of urine. So there's actually an infected backup of urine, right? So that stagnant water, if there's a UTI and we have an obstruction and we have that backflow, we really don't want that stagnant urine backing up into our renal kidney. Or I should say our renal pelvis, excuse me. So we're looking for hydronephrosis. We're looking for any anatomical abnormalities. Is there any strictures? Is there abscesses? Is there stones? A CT scan can be very helpful for diagnostic. It can also help us assess if there's any impaired kidney function. Is there inflammation going on? Is there scarring? Is there an abscess? And again, the percussion for CVA, and if that's positive, that would be another good diagnostic test. And treatment, how do we treat pyelonephritis? So we need to monitor and treat the symptoms, okay? So we're in the acute phase. So if there's any pain going on, we want to treat the patient's pain. If they're having any nausea or vomiting, we want to treat them, with those type of medications. If there's a fever, we would want to treat the fever. Again, like I said, opioid medications or NSAIDs would be very helpful, especially if they're having a lot of pain. Anti-nausea medication, IV fluid hydration, administering a broad spectrum antibiotic. And of course, we want to know the sensitivity to that. What's the most important thing we want to watch for with pyelonephritis? Yeah, sepsis. So urosepsis, septic shock. And what is the patient's presentation if they were to be in urosepsis or have septic shock? Yeah, they'd probably be becoming hemodynamically unstable. So we'd be losing a blood pressure. They'd be hypotensive, and we would be more tachycardic. Our heart rate would be high. Okay. I love this slide. I think it's a great slide for you to know. So it just, again, goes over, we have fever and chills with pyelonephritis. We have the dysuria frequency and urgency. We can have the flank pain, the CVA tenderness, and the nausea and vomiting. So again, very, very similar to a UTI, just more extravagant. Please know the microbiology. So E. coli is very, very common. It's like 75 to 95% of the problem. Proteus, Klebsiella, and Staph. The less common microorganisms would be septicemia and infective endocarditis, causing pyelonephritis. Very not common at all. And management. And if it's a mild to moderate case of pyelonephritis, we'd be giving either the ceftriaxone, or known as Ancef, the ciprofloxacin or levofloxacin, and estrianem. If it's more of a severe case, we're going to be giving more of a broad spectrum antibiotics, cefepime, piperacillin, or also known as Zosyn, or the meropenem. So please know this slide. And then we can move actually into chronic pyelonephritis. So with patients, and I wanted to talk a little bit about Foley care and Caudi's, which is so important. And I know you guys know how quickly they like to take catheters out now today. They don't like them in long, and this is why. So what Foley care do you provide to your patient? So we want to make sure that our bag's hung below the level of the bladder, right? We don't want our bag hanging on a bed rail that can move up and down, which can pull the catheter out. We want to make sure that the Foley bag is hanging on the frame of the bed. We don't want the bag to be overflowed where it can actually back up into the tubing and cause an infection. So we want to make sure that we're emptying that bag at least once a shift, or if there's a larger amount of voiding or urination, that we're emptying it more. Of course, pericare is huge when placing your Foley, aseptic technique. That's a big deal. A cath secure, making sure that there's not a lot of movement at the meatus. So catheter-associated urinary tract infections are CAUTIs, okay? So what we can do to help prevent these is first, hopefully avoid any unnecessary catheterization. So keeping patients away from catheters as long as we can, and really determine the need if they do need one. Of course, if there is skin issues like major skin breakdown, or if we really need strict intake and outputs, a Foley would be beneficial, but we really want to stay clear of catheters as much as we can. Early removals. So really we do this nursing-based removal. That's kind of new to BMC. And that's under the acronym Houdini, and we'll look that up in a second. Also on rounds, so when the providers round, they really go over the need to have a Foley, and a lot of times they'll want that discontinued for that day. Aseptic technique, again, washing your hands, pericare is a big deal. And always document your care and give yourself credit for the care you're giving for Foley care. And that is all. Thank you for listening, and I hope everyone has a great day.